So we can go now, right now. Okay, moment. Oh, shit. What is this? One moment, please. So can we already start presenting?
Yes, doctor, please start.
Okay, thank you very much for inviting us to this lovely conference. Today we want to share with you our experiencing in conducting a new and innovative intensive trauma treatment program for adolescents. We did our research while working at ACARA. ACARA is an institution for child and youth psychiatry in the north of the Netherlands, where both outpatient and inpatient treatment is offered for adolescents up to 23 years old. And their system. We, at that time, worked in the clinic at the adolescents department. And later on, you will see a video of the location. While setting up an intensive trauma-focused treatment program for adolescents, we decided to also do this research on its effectiveness.
Well, let's start by introducing ourselves. Next to me is Ytje from Pelt. She's a mental health care specialist, a cognitive behavioral therapist and trainer, EMDR Europe consultant and trainer and researcher at PSYSO specialized mental health care and education. My name is Petro Fokkema. I'm working at Trivio Care as a mental health care specialist, cognitive behavioral therapist and trainer, EMDR consultant from EMDR Europe and researcher.
Now let's start with a small video fragment. We will show you a video of Rijnwold. And Rijnwold is a village that became world news in October 2019, when a policeman, a whole police team discovered a father with 5 adult children in a remote farmhouse. The children were not registered, did not attend school, and had been living in total isolation in a locked room of the farm for years, waiting for the end of time. It was son Israel, then 25 years old, who had fled from the farm shortly before and who, in a completely confused state, had asked for help in a local cafe. 3 children, Shin, Edino, and Marianne, had previously fled from the farm on their own. When the discovery of the family became world news 2 years ago, they decided to make a documentary about their lives. And the Dutch watched the broadcast with bated breath, in which the 4 oldest children tell about their past and their terrible memories of their father. We want to show you a short introduction of the documentary in which the anger, the fear, but also the love and the compassion are visible.
Kom als ermee, doe het en doe het. Ja, je was wel gewoon echt bang.
Zij was ook fysiek agressief.
Ja. Dan ging die zo lang wurgen tot je dan bijna het gevoel had dat je doodging en dan niet hier los. I want to surf. I want to surf. Het beste is gewoon maar er helemaal niet over te praten en maar net te doen op school alsof Israël er helemaal niet zijn. Ja?
Als jij dan de geest van je moeder belichaamde voor hem, behandelde hij jou dan ook anders?
Ja, dan zag hij mij gewoon echt als zijn vrouw. Als je met hem sliep en zo, was het gewoon hetzelfde.
Seksuele handelingen?
Ja, dan ging hij zo lang wurgen tot je dan bijna het gevoel had dat je doodging en dan niet hier los.
moeder die zit gewoon op de stoel en die zit een soort van ook lachend bij. En dat gaf voor mij ook wel echt duidelijk weer van, nou ja, van je laat het toch met je kinderen gebeuren. Ieder kind mist op een gegeven moment gewoon zijn ouder. Ik denk, dat zit er ook gewoon heel erg. Weet je, dan, je wil niet de vader in de gevangenis en je wil niet de moeder die overleden is. En weet je, dat wil je niet.
Well, these are the children of Ruinewold, and they show us some PTSD problems they have. When we speak of PTSD or trauma, then it's someone is being exposed to one or more traumatic events directly, so as a victim or a witness, or indirectly heard about them from a close person, for example, and shows a minimum number of symptoms of 4 clusters. The first cluster is intrusive symptoms, such as flashbacks or nightmares. The second cluster is persistent avoidance of memories, thoughts, feelings, people, or places that remind them of the traumatic event. The third cluster is negative changes in cognitions and mood, such as exaggerated negative beliefs about oneself, others, or the world, or reduced interest in activities. The fourth cluster is an increased arousal and reactivity. The symptoms are present longer than 3 months.
So let's take a look at the typical reactions in this developmental stage of the adolescents. We see shame of their own vulnerability or dependency. And this is a developmental stage where the adolescent wants to be independent, wants to do things on their own, wants to make own choices. We also see fear of being found different or abnormal, like being crazy, or we see also aggressive and destructive fantasies. We see radical changes in the negative core beliefs, as Petra already told us. We see the developmental of risky behavior, like driving a car with no license, or passing the street with the eyes closed, but also think about substance abuse, for example. We also see a reenactment in behavior. And the tendency to repeat. So the trauma can go on and on and on, because they will be re-victimized again and again.
Well, before we tell you more about our new and innovative intensive trauma treatment program for adolescents, we want to share some statements with you. To inventory your opinion on trauma treatment in adolescents. These statements can only be answered digitomously. So if the proposition is a fact, then raise your digital hand. And if it's a myth, you don't have to do anything.
Just sit and relax.
Sit and relax. We start with statement 1. It is irresponsible to start trauma treatment for adolescents without a stabilization phase in which the adolescent learns emotion regulation skills. Well, we can't see you, so it's a little bit difficult.
Maybe you can place the digital hand or no into the chat so we can see the reactions.
Yes.
Let's take a look at the chat. You don't see anything. Maybe you need a little bit time. No, we see no reactions. Maybe we just can continue.
Yes, we'll go on.
We will go on.
Yes.
Okay, as you can see on this slide, there's already a substantial body of experience, scientific evidence for the earliest possible deployment of trauma-focused treatment. And in any case, the severity or complexity of these symptoms do not seem to be valid arguments for offering patients a course of stabilization. are denying them treatment according to the multidisciplinary guideline for anxiety disorders. And you need to offer trauma-focused cognitive behavioral therapy or EMDR therapy. Let's go to position 2.
Yes.
A small reminder,
Well,
maybe
yes.
raise hands
Yeah.
into the chat if you want to react, and otherwise you don't have to do anything.
Well, trauma treatment for adolescents should be offered in doses, meaning at a maximum frequency of 1 therapy session per week. That's the standard, the regular situation, 1 session trauma therapy per week. What do you think about this statement?
We don't see any hands, so maybe we just continue.
Yes,
and
we'll
everybody can
continue.
do it in their hands. Now, is it a fact or a myth to dose or not? And there has been body of research into the intensive variance of research with adults. Ehlers and colleagues published an article in 2014 following their research into an intensified form of trauma-focused treatment in adults with chronic PTSD. They had a large number of participants. Here you can see the blue line. The blue line was the cognitive therapy for PTSD, an intensive daily trauma-focused treatment, 7 days in a row. The red line means the cognitive therapy for PTSD standard weekly with a duration of 3 months. The green line is the emotional focused supportive therapy offered weekly for 3 months in a row. And the purple line is the waiting list, where the participants were waiting for 2 weeks. If we look at the effects, the recovery from the PTSD, the blue line shows 73%, the red line shows 77%, the green line shows 43%, and the purple line shows 7%. So in summary, results suggest faster symptom reduction while being compared to the traditional treatment approach. Also, there was no higher dropout or worsening of symptoms. So, more recent, Woudenberg and colleagues in 2018 did great research in the Netherlands at the Cytrek clinic. And they have been developing a program for adolescents, for adults, wherein they combine several evidence-based treatment therapies. That means prolonged exposure in combination with EMDR therapy and physical activities with psychoeducation. And their research shows that it's a safe program, well tolerated, effective, and shows a high level of patient retention.
Yes.
So let's continue.
Well, Mavison and colleagues offered an intensive trauma treatment program for families. Also 2 sessions per day, 4 days in a week for the duration of 6 weeks. There were included 9 parents and 10 children, and they stated that a therapy program for parents and children consisted of 2 sessions of 60 to 75 of 75 minutes per day, 4 days a week, was conducted by multiple therapists. And between sessions, family members were supported by the carer who encouraged them to be physically active. And as you can see, after 2 weeks, 90% of the children and parents no longer had the diagnosis PTSD. There was no dropout, and there was a significant reduction in psychopathology, and the results also maintained after 6 months.
So very promising results. It was a small amount of participants, but very promising.
Yes.
So Hendricks also did research, very nice research of the Netherlands in 2017. They offered an intensive prolonged exposure therapy program for adolescents. The participants were 10 adolescents with severe PTSD and comorbid disorders after multiple interpersonal trauma. They showed no dropouts, and 40% of the adolescents reached diagnostic remission of their PTSD symptom from baseline to post-treatment, and 80% even from baseline to follow-up at 3 and 6 months. So the results even maintained and growth after the treatment.
Yes. So what we can say is that intensifying trauma-focused treatment may lead to better treatment adherence, possible because there are fewer interfering variables that may play a role, such as reduced time between therapy sessions to build up anticipatory anxiety. So it's a nice outcome.
So let's take a look at position 3. Again, if you want to show your face and raise a physical hand, or you want to show a digital hand in the chat, you are very invited to do that. In position 3, it is best to use different trauma-focused methods within the trauma treatment, meaning to combine different trauma therapies. Is it a fact or a myth?
Well, in an exploratory study of Van Minnen et al. In 2020, they examined that prolonged exposure therapy and EMDR therapy can be successfully combined, and that the sequence of offering the therapy matters. The results showed that the patients who received prolonged exposure therapy first and EMDR therapy second showed a significantly higher reduction in PTSD symptoms compared to patients in the EMDR first condition. Moreover, patients preferred this PE first EMDR second condition and valued the treatment sessions as significantly more helpful in this condition. So they prefer this combination, prolonged exposure first, EMDR second. The question is whether a combination of two first choice guideline treatments for PTSD, prolonged exposure and EMDR therapy, leads to a better treatment outcome regarding PTSD and comorbid symptoms than a non-combined trauma-focused therapy. Because these therapies seem to be based on different working mechanisms. It is conceivable that prolonged exposure is better for some patients and EMDR for others. As far as we know, however, it is not yet known which trauma-focused treatment can best be used for which specific symptoms. By combining these two therapies, we expect an increased value on the therapy effect.
But further research is very welcome.
Yes, it's necessary.
It's necessary.
Yeah.
So let's take a look at the adolescents perspective of the combination of therapies. And we asked our adolescents in our study to, how do you think about the combination? So some said prolonged exposure made me see all the details. And with EMDR, that became more and more difficult. Most of them stated that the combination was good for them. Through prolonged exposure, they learned to talk about the shitty side and the hard side of it. And they couldn't do that at first. And one said, it's a typical adolescent response. Prolonged exposure is a special therapy, stupidly talking with someone who's trained for it. So more than one participants stated that by seeing the combination the combination worked very well for them, and that that it provided more structure and relief. So
yes,
that was their perspective. So
well, we'll take you to the final position. And this position is about in the context of CPTSD trauma-focused therapy, it is best provided by one therapist, so the adolescent regains confidence in adults. Is it a fact or a myth? Well, we'll tell you.
take a
Yes.
look. So the therapist rotation model, and maybe it's a relative new model for you. It's made by Van Minnen, one of the Netherlands psychologists and researchers in 2018. And the therapist rotation is a novel approach for implementation of trauma-focused treatment in post-traumatic stress disorder. And results described in the article by Van Minnen, written by Van Minnen, suggest that the therapist rotation is an emerging approach in which a reduction in therapist fear can be shown. Therefore, the fear of applying trauma-focused treatment is downsized. Also, the awareness of trauma-focused treatment and avoidance behavior is minimized. Which may lead to a better implementation of trauma-focused treatment. Also, the therapeutic alliance is assessed as good by the clients. Also, when it was the case of an insecure attachment style. So the conclusion, it is a promising emerging approach to improve the implementation of trauma-informed treatments.
Well, then we asked the adolescents in our study, what is your perspective on therapist rotation? Because it's a new thing, they hadn't done it before. Some patients had about 7 to 10 different therapists, and they said it was fine. The advantage is that you do get confidence in people, and they also have different visions, look at something differently, and that can give you a wider view. Another one said, if you always have the same one, you get into each other's face too much.
It's a typical developmental stage.
Yes, but we can understand
that.
Actually, it was working together, the feeling of a team around me. That's something they said a lot.
That was really striking. Eh?
Yes.
They felt a team.
Yes.
Although there were lots of therapists.
Yeah, they saw a lot of therapists, but they felt like a team around them. They also said everyone is different and that has a different effect on me. Well, I can't read the slides any longer, but there's one client said, I didn't like it. Always someone else is annoying, and she didn't prefer it, but what is very nice, that she had the largest decrease in PTSD symptoms in treatment of all the clients. So she didn't like it, but it had a good effect on her.
Yeah. So then we will give an introduction of our research. When we look at the study results, we see a high dropout rate, and that has big consequences for the adolescents in this developmental stage. We already talked about re-victimization, the fear of repeating and over again. So this is the stage to offer an effective treatment. But when we do offer it, there's a high chance of dropout. So with the emerging evidence for intensifying treatment as seen in the field of adults, and the study of Hendricks we already told you about for adolescents, we thought, okay, so these programs are very well tolerated, they are safe, they are effective, and the patient retention, there's a high level of patient retention. So the question arises, at our case, from whether this also can be applicable for adolescents. Yeah.
Yes, because we wanted to do something with a high dropout rate. And when there is dropout, the consequence is that a significant number of children and adolescents ultimately do not receive treatment they could benefit from. And we wanted to break through that with our program.
So The purpose of our study was to determine whether this brief trauma-focused treatment program could also be effective for adolescents with severe PTSD following interpersonal trauma, measured by using the golden standards for classifying PTSD in children and adolescents. We call that the CAPS-K.
Yes, and we predicted that this treatment program for adolescents would be associated with a significant decrease in PTSD symptoms, as well as a decrease in the number of adolescents fulfilling the diagnostic criteria of PTSD. Furthermore, we predicted a low dropout rate and that the treatment program would be safe, which means an absence of adverse events, such as no increase in suicidal ideation, no serious self-injurious behavior, and no crisis contacts.
Yes. So let's take a look at the background of this study. We already told you about, but we wanted to show this brief photo of the article of Van
Yes.
Woudenberg,
And
because it is very nice
Yes.
to read it. So,
Well, the patients we included in the study received a trauma-focused treatment for the duration of 2 to 4 weeks. And in this period, 27 participants, most female participants, were referred by their general practitioners, psychologist or psychiatrist from an outpatient service to our intensive care department for trauma-related problems in the Netherlands. Of these patients, we consecutively included individuals fulfilling the following criteria. They have been aged between 12 and 18 years. They were meeting the diagnostic criteria of PTSD according to the DSM-4. And had received trauma-focused treatment in an outpatient setting, which was stopped prematurely due to severe dysregulation, or trauma-focused treatment had not been started because the risk of such adverse events occurring was deemed too high by the referring clinician.
so that was a very important point for us.
Yes.
Before you go to a clinic for an intensive program, the outpatient program has been offered already, or yeah.
Yes.
Okay. Now, we had a lot of phases. The first was the preparatory phase, the phase in which we applied the orientation interviews. We did all the measurement instruments, and we made a trauma-sensitive case conceptualization. We also offered psychoeducation to the caregivers, to the parents, to the adolescents, to everyone who is important for the patients. The processing phase was the ITT program, the intensive trauma treatment program, in which the combination of prolonged exposure in the morning with exposure in vivo combined with exposure in vivo, followed by physical activities for 60 minutes therapy, 60 minutes physical activity in the group, followed by 60 minutes EMDR therapy, and again 60 minutes physical activation in the group. The last phase was the consolidation phase, in which the focus became on the transfer from everything you have learned, everything you have reached from the clinic to the home, the own environment.
Yes. Well, Ytje told you about this daily program. You can see it on the slide. What's important to say is that at noon, the multidisciplinary consultation took place, and there patients' information about their trauma history and PTSD symptoms was used for a case conceptualization, and was used to get all the therapists working with one client on the same track. So everybody was working in the same direction. The therapists rotated between the individual treatment sessions, which meant that patients had approximately 5 to 7 different therapists in a week. The therapists provided psychoeducation about PTSD before and during the treatment program. And in addition to the daily treatment schedule, the patients spent the remaining hours of the day either together with the rest of the patient group, for example, during meal times or leisure time, but also they could work on their school assignments, or they could receive visitors from their own network during the leisure time. Well, in the weekends, they went home. And further, the treatment program did not contain any form of stabilization, in that prior to the processing of the traumatic memories, no relaxation or emotional regulation skills were trained.
So let's take a look at the clinic. So here you can see the beautiful grounds of the clinic where the young people stay during the treatment. You can see some of the attributes we used during the exposure in vivo, such as alcohol, tobacco, but also fake penises. Let's take a walk around the grounds. You can see the woods and also the hidden cottages behind the trees. And here you can see the practitioner who is specialized in boxing training for young people. He explains the purpose of boxing. The first aim is to be able to unload, to get out of your head for a while and just enjoy boxing. The second aim is to increase the heart rate in order to continue processing. And the last goal is to experience strength within your own body, and to experience what you can do with your body in order to feel better and stronger mentally. And here you can see the EMDR therapy applied by the practitioner. Besides boxing, we also offer guided running, mountain biking, fitnessing, basketball, and here you can see the boxing. And all the activities are being offered in a group in order not to only activate them, but also to let them interact with other young people. And the so-called social context with is of great importance of this specific age group. So in the last shot, you saw a beautiful house, beautiful cottage. Everybody has their own room in the cottage, and they can also invite friends or family members. Everyone is welcomed, besides the hours where they offered therapy. So
yes. And Ytje told about that the activities were offered in a group, and that's all the activities besides the individual therapy, prolonged exposure, EMDR therapy.
yes, yes.
Well, here you can see the comorbid disorders of the clients we included in our study. The problems that occurred most frequently, in addition to PTSD, were mood disorders and developmental disabilities. Anxiety disorders and personality disorders also occurred. On average, the adolescents in the study had 2.2 disorders besides PTSD.
So PTSD and
yes,
again two comorbid problems at least. Yes. Okay, now here you can see the traumatic events. Domestic violence was the biggest percentage, maltreatment, and also the sexual abuse. Yeah, and most of them in combination of maltreatment with sexual abuse in a home with domestic violence. Yes.
Well, the presence of a PTSD diagnosis and the level of severity of the PTSD symptoms were assessed using a clinician-rated interview by independent assessors. The assessment was carried out prior to treatment, at the end of their treatment, and at follow-up 3 months after treatment.
So let's take a look at the total mean scores from the CAPS-K at pre-test, post-test, and at follow-up. In the study, we included 27 patients. They had a mean age of 16.1 years. Sorry, excuse me. The majority had a very high PTSD severity score measured by the CAPS-K, as you can see in the first, the pre-test, with a total mean score of above the 80. at post-test, and all of the patients had been exposed to one or more interpersonal traumatic experience and displayed a high level of comorbidity as shown by Petra. At the end of the treatment, you see at the post-test, the scores were lowered, even above, how do you say it? It's even half
Half
of the scores.
the first score.
Yes. And you see at the follow-up, it continues. So it doesn't move, doesn't get better, but it also does not get any worse. So that's nice. The biggest promising effect for us, stunning, was that none of our patients dropped out during the treatment. So that was a big surplus value of our intensive program. So the majority of these patients, and then we speak about 81.5%, showed a clinically meaningful response to treatment based upon a classification. And at the end of the treatment, 63% no longer fulfilled the diagnostic criteria of PTSD. So very promising.
And there
results.
was no symptoms worsening.
No.
Yes, okay. Well, the results, Ytje told us, there's a significant decrease in CAPS-4 scores from before to after treatment. 81.5% had a clinically meaningful response, and the average admission time was 13 days of treatment. So 13 days with weekends in between. 63% no longer met diagnostic criteria of PTSD after treatment, and the dropout was 0. The results maintained after 3 months of follow-up, and no adverse events happened.
So we conclude that it's a safe and effective form of treatment for adolescents with very severe PTSD and comorbidity after a series of chronic traumatic events. And again, small reminder, no dropout, and that was very stunning for us.
Every client could get them.
Yeah. So at least at last, we asked the clients to give you a message to every practitioner in the world. And what do you want to tell them about the program? So they said, there are a lot of messages, but we can make it smaller. So just do it. Back to earth with an ITT in intensive trauma treatment, and hand in hand we extinguish the trauma fire. ITT, we go to SAT-3. In the trauma focused treatment, we measure the subjective unit of the stress on a scale from 0 to 10, and they said go back to -3. ITT, something so effective you don't often see. Now that's a good idea. Start it right away. It's the only way, and this was really stunning for us because it is so hopeful. An ITT for anyone with a complex case. So thank you very much for your attention. We would like to ask you if there are any questions.
You can also send us an email.
Yes, of course.
We showed it on our first slide. We could put it in the chat also.
Yeah.
Well, thank you very much for your attention. And
maybe there are any questions.
Are there questions?
Are there any questions?
Thank you so much, doctors, for your